Hello guys, Assalamu alaikum. I am Dr. Faraz Ahmed, and from today we are going to start these audio podcasts for PLAB1 examinations. And in these sessions we will cover the different topics related to PLAB1. So in today's session we are going to cover the cardiology topic. So first topic from the cardiology is acute coronary syndrome. So guys, please keep in mind that ST elevation MI, non-ST elevation MI, unstable angina, we include all these in the acute coronary syndrome. So first of all we will talk about the presentation of acute coronary syndrome. Patient can present with a chest pain. That chest pain can radiate to left shoulder or the left arm. This may be a non-radiating pain as well. In addition to that, patient can also complain of radiation of this pain to the jaw. Okay, sometimes the patient can complain that I am having the feeling like some elephant is sitting on my chest. So if some patient present with these complaints, so what we will do? First of all, we will do the ECG. If there are ST elevation in the ECG, definitely this is ST elevation MI. If there are no elevations in the ECG, what we will do? We will keep the patient in under our observation and we will order troponin test in 6 hours. If troponin tests are normal, that would be unstable angina. If troponin tests are positive, so we will conclude this that a patient is suffering from non-ST elevation MI. So let me tell you that how we will manage these cases. So first of all, we have done the ECG, we have done the cardiac markers, ECG, ST elevation. There is ST elevation in the ECG, ST elevation MI, and there are no ST elevation, drops are positive, then definitely there is non-ST elevation MI. So first of all, what we will do? First of all, we will do the IV morphine for the pain relief. We will attach the oxygen, we will give nitrates, we will give aspirin, and we will give heparin as well. So all these things include in the ACS protocol. So this is the management in the acute setting. So what we have to do for the definitive management? Definitive management, we have to do angioplasty if patient is presented within the 12th hour of the onset of the symptoms. So this is a gold standard. Basically this is called PCI, percutaneous coronary intervention. This is the gold standard treatment for the ST elevation MI. So if ST elevation MI, so if PCI option is not available, then what we will do? We will select the alteplase option, that is the preferred over the streptokinase. But here in the Pakistan, in most of the cases we give the streptokinase injection for the thrombolysis in the case of the acute MI. So guys, I would like to mention that if patient presented with the ST elevation MI, how you will say that this is inferior wall, this is lateral wall, and this is the anterolateral wall. So if there are ST elevation in lead 2, 3 and AVF, definitely this is inferior wall MI. If there are ST elevation in 1, AVL, V5 and the V6, this is lateral MI. If there are ST elevation in V1, V2, V3 and 4, you can label this as anterior or anteroseptal MI. If there are ST elevation in 1, AVL, V4, V5 and V6, that is anterolateral MI. Now I would like to mention that if some patient is having inferior wall MI, which artery will be occluded? So if someone is having inferior wall MI, definitely we will select right coronary artery occlusion. Lateral wall MI, left circumflex artery occlusion. Anterior wall or anteroseptal MI, left anterior descending artery occlusion. If someone is having the anterolateral MI, then left anterior descending artery or left circumflex artery could be involved. So guys, now we have treated the patient in the acute setting. So please keep in mind that there are 5 long-term or the chronic management drugs in for the MI patient. So we have to give 2 drugs for 12 months and 3 drugs for life. So 2 drugs which we will give the 12 month, that include the clopidogrel and beta blockers. Clopidogrel and beta blocker will be given for 12 months. Aspirin, ACE inhibitors and statin will be given for the whole of life.
So after myocardial infarction, we will discuss the important complication of MI. It includes cardiac arrest, chronic heart failure, tachyarrhythmias, pericarditis, Restless Syndrome, left ventricular aneurysm, ventricular septal defect, and acute mitral regurgitation. So the important thing in complication is to remember the duration, which is really important to diagnose the complication. So first of all is cardiac arrest, which is the most common complication which occurs after ventricular fibrillation, and the treatment is by giving defibrillator. Next is chronic heart failure. It occurs due to the dysfunction of myocardium, and the management includes first of all the symptomatic relief by giving loop diuretics, which is furosemide. Secondly, we start with either AC inhibitor or beta blocker, and if the symptoms persist, we will give the other drug. Like if we have already given AC inhibitor, we will add the beta blocker, and vice versa. If the symptoms still persist, we will add spironolactone. Now the third complication is tachyarrhythmias, and the ventricular fibrillation is the most common among tachyarrhythmias, and it is also the most common cause of death after MI. Its management include administration of oxygen, and we will check the pulse of the patient. If there is no pulse, we will give arrest protocol immediately, and it includes defibrillation. Now come to the most important complication, which is pericarditis. The important thing to remember about pericarditis is the time duration, as it occurs after 48 hours or 2 days of myocardial infarction. Its features includes pleuritic chest pain, which is worse on lying flat and during inspiration, and the patient will feel better when he sit in bending forward position. Along with these clinical features, patient have fever and pericardial rub. On chest X-ray, it will show by enlarged globular heart. On ECG, it will relieve widespread saddle-shaped ST elevation with upward concavity and PR depression. And the treatment is by giving NSAIDs for at least 7 to 14 days. Next is Restless Syndrome, which is same as pericarditis, but the main difference is the time duration, as it occurs after 2 to 6 weeks following myocardial infarction. And the most important is pathophysiology, which is basically an autoimmune reaction against antigenic proteins forms as the myocardium recovers. The clinical features are same of the pericarditis along with pericardial effusion and raised ESR. The treatment is same by giving NSAIDs. Now come to the left ventricular aneurysm. It occurs as a result of ischemic damage which sustained during an MI episode, because it will weaken the myocardium, resulting in a muscular layer which become very thin, and a swelling or aneurysm is formed. It also occurs after 4 to 6 weeks of myocardial infarction. And the complication of aneurysm is stroke, because a thrombus may form within the aneurysm, so it is very important to anticoagulate the patient. Now what are the findings on ECG? There is persistent ST elevation and left ventricular failure. On chest X-ray, there is enlarged heart with a bulge at the left heart border, and on echocardiogram, paradoxical movement of the ventricular wall will be seen. Next is ventricular septal defect. In this case, there is basically a rupture of the interventricular septum, and it also occurs in the first week after MI, and it is seen in 1 to 2% of the myocardial infarction. The most important feature is pan-systolic murmur, and the diagnostic is echocardiogram. As there is rupture of the septum, so urgent surgical correction will be needed. And the final complication is acute mitral regurgitation. It is also very important, and it occurs after 2 to 15 days of myocardial infarction. The most common thing is pan-systolic murmur, which can be heard, and it occurs due to ischemia or rupture of the papillary muscles, so it will also need a surgical replacement. The clinical features are hypotension, tachycardia, and pulmonary edema, and it will be diagnosed on echocardiogram. So the easiest way to remember this complication is that you can combine pericarditis and Restless syndrome as the clinical features, ECG findings, and treatment is almost same, and the main difference lies in the duration, as pericarditis occurs after 48 hours or 2 days, and Restless syndrome occurs after 2 to 6 weeks. Next we have ventricular septal defect and acute mitral regurgitation. Same occurs here. There is the major difference lies in the duration. Like VSD occur after first week of MI, and mitral regurgitation occur after 2 to 15 days. Rest of the clinical features are same, as both have pan-systolic murmur, both are diagnosed on echocardiogram, and in both of the cases there is rupture of the muscle, so we will need a surgical correction.
Okay, so next topic is the cardiac tamponade. So cardiac tamponade is basically the accumulation of the fluid in the pericardial cavity. So please keep a triad in your mind so that you can easily diagnose the cardiac tamponade. That triad is a Beck's triad. So this include hypotension, muffled heart sound, high JVP or distended neck veins. So please keep hypotension, muffled heart sound and distended neck veins in your mind. You can easily diagnose cardiac tamponade. So basically cardiac tamponade, the most important cause for the cardiac tamponade is the trauma. And first of all, what you will do the chest x-ray and you will see that there is an enlarged globular heart on the chest x-ray. Then what we will do, the definitive diagnostic test for the cardiac tamponade is the echocardiogram. So and the definitive treatment for the cardiac tamponade is the urgent pericardiocentesis. So please keep in mind, if question asks you what is the initial management, initial treatment of the cardiac tamponade, what you will select, you have to select about the IV fluid because patient is presenting with hypotension. So I would like to mention here one more important thing, that cardiac tamponades can also develop as a complication of MI. As we have just mentioned in the previous topic, that MI can lead to the acute pericarditis. Acute pericarditis can lead to the pericardial effusion, and pericardial effusion can lead to the cardiac tamponade. So next topic is infective endocarditis. For infective endocarditis, you have to keep three things in your mind. First thing is that if some patient is presenting with fever and a new heart murmurs, you have to think about infective endocarditis. Fever and a new heart murmur, think of infective endocarditis, and you have to do what? Initially you have to order blood culture. Fever plus new murmur, you have to think of infective endocarditis and you will order initial investigation, that is blood culture. And keep in mind that diagnostic investigation, the confirmatory investigation for infective endocarditis is echocardiography. Okay, so let's talk about the risk factor. Basically the strongest risk factor is the previous episode of endocarditis, rheumatic valve disease and prosthetic valve. These are basically the major risk factor of the infective endocarditis. So always keep in mind that what are the causative organism of infective endocarditis. So in general, the most common cause is the Staph aureus. If some patient have a prosthetic valve and then he developed the infective endocarditis, the most common cause of infective endocarditis in prosthetic valve is the Staph epidermidis. Okay, if some patient had dental surgery in the past, now he developed the infective endocarditis, the causative organism could be Streptococcus viridans. Okay. So guys, always keep in mind that there is a modified Duke criteria for the diagnosis of infective endocarditis. So always keep in mind that infective endocarditis is diagnosed in any of the following situation: when there are two major criterias and one major and three minor criterias, or five minor criterias. If some patient have two major criterias, infective endocarditis is diagnosed. One major criteria or three minor criteria, infective endocarditis is confirmatory. If patient have only minor criterias, and that should be five minor criterias. So now we will talk about the what are the major criterias and what are the minor criterias. There are basically two major criteria and there are five minor criteria. Among the major criteria, there are two criterias in the major category. Number one is the positive blood culture. If there is a positive blood culture and there is a evidence of infective endocarditis on echocardiogram, then definitely patient is diagnosed case. So two major criteria is a positive blood culture and evidence of infective endocarditis on echocardiogram. There are five minor criteria. Number one is the intravenous drug abuser. If patient is intravenous drug abuser, one criteria is fulfilled. Microbial evidence that does not meet the major criteria. Okay, so this is the second minor criteria. If patient had fever more than 38, there should be vascular phenomena like splinter hemorrhages, Genvalians and petechiae or the purpura. So vascular phenomena is the fourth minor criteria. The fifth one is the oscular nodes, root spots. So if patient have any of these five features, then five minor criteria are fulfilled and patient would be a final diagnosed case of infective endocarditis. Okay, now I will tell you that how we will manage the infective endocarditis. Basically, we start the antibiotic therapy. Empirical antibiotics for the infective endocarditis include, if there is a native valve endocarditis, then we will start with the amoxicillin and low dose gentamicin. If patient is allergic to penicillin, then we will not give the amoxicillin, we will give vancomycin and low dose gentamicin. Okay, if patient had a history of prosthetic valve endocarditis, then we will give vancomycin, low dose gentamicin and rifampicin. So at the end, I would again repeat that if some patient is presenting with fever and a new heart murmur, you have to think about infective endocarditis, and the initial investigation of infective endocarditis is blood culture. So to confirm the infective endocarditis, we will do echocardiogram. Thank you very much. So next we will discuss about the heart failure and pulmonary edema. So please keep in mind, whenever some patient present with lower limb edema, dyspnea, orthopnea, and on echocardiogram ejection fraction is less than 40%, then heart failure is diagnosed. Okay, so please keep in mind that if patient is presenting with lower limb edema, dyspnea, orthopnea and ejection fraction is less than 40, then heart failure is diagnosed, and you have to start the management of the heart failure. If patient is presenting in the emergency with these features, then for the symptomatic relief we will give the diuretics, and please keep in mind we will give loop diuretics, furosemide. So once the acute phase of heart failure is resolved, we will send the patient home and we will start medication. So first of all, we will start ACE inhibitors, or we can also start beta blockers. Like if we are starting ACE inhibitors and symptoms are not resolved, then we will add beta blockers, and vice versa. Okay, if symptoms are still there, if we are giving ACE inhibitors and beta blockers but symptoms are not resolved, then definitely we can add spironolactone. One thing here I would like to mention, that if patient is diagnosed with heart failure and patient is a diabetic, then we have to start with ACE inhibitors. Now after the heart failure, we will discuss about the pulmonary edema. Pulmonary edema is basically a complication of heart failure. Now I will explain the mechanism of pulmonary edema. Once there is a congestive heart failure, the heart is unable to pump the blood effectively. Okay, so blood may return into the veins, and then fluid from the blood can come to the lungs. So this will lead to the pulmonary edema. So now I will tell you the features of pulmonary edema. Patient will present with the feature of low oxygen. Like patient can present with oxygen saturation in 80s, and patient can present with a dyspnea, orthopnea. Patient will say that whenever I lie down, I am unable to catch my breathing. Okay, so patient can present with these complaints. In addition, when you will auscultate the chest, you will hear the crepitations or crackles, and patient can also complain of tachycardia. So what you will do? So please keep in mind the very initial investigation, and the most appropriate investigation for pulmonary edema is a chest X-ray. Keep in mind the most initial and most appropriate investigation for pulmonary edema is chest X-ray, and the investigation to identify the underlying cause is the echocardiogram. So whenever there is a case of pulmonary edema and they ask about the most appropriate and the most initial investigation, then you will select the chest X-ray, not the echocardiogram. Echocardiogram is basically identifying the underlying cause. So now we will talk about the management of the pulmonary edema. As I have just mentioned, that if patient is presenting to the emergency department with the low oxygen saturation, and patient is presenting with the dyspnea, orthopnea, tachycardia, and there are crepitation, what you will do? You will definitely attach the oxygen, you will give the nitrates sublingually, and you will also give the morphine or diamorphine for what? For pain relief, and you will give the furosemide Lasix as well. As I have mentioned in the heart failure, that for the resolution of acute phase, we give the furosemide, that is diuretic. So here in the pulmonary edema, management is also the same. Okay, so one thing I would like to mention that how we can differentiate pulmonary edema and pulmonary embolism. So always keep in mind that pulmonary edema is diagnosed on chest x-ray. As I have just mentioned that in pulmonary edema the most initial investigation is the chest x-ray, while pulmonary embolism is not diagnosed in the chest x-ray. Pulmonary embolism is diagnosed in CT pulmonary angiogram. So now I will tell you that what we can see in the chest x-ray when patient is presenting with pulmonary edema. So you can see curly B lines in the chest x-ray, and you can also see the bat wing appearance in the chest x-ray. So if there are curly B lines and there is bat wing appearance in the chest x-ray, then definitely you can say with a surety that this patient is a case of pulmonary edema, or the underlying cause of pulmonary edema in most of the cases is heart failure. Next, I will tell you about some protocol which are usually observed in cardiology. So if some patient is hypertensive and patient is taking ACE inhibitors for hypertension, and patient present with the cough, so what you will do? Definitely ACE inhibitor side effect is the dry cough. So you will stop ACE inhibitors and you will shift the patient on angiotensin receptor blockers. So you will stop ACE inhibitors and you will shift on the ARBs. Alright. So if some patient is hypertensive and he is taking calcium channel blocker, like he is taking diltiazem and he is taking amlodipine, and patient present with ankle edema or patient present with gingival hyperplasia, so what you will do? You will stop the calcium channel blocker and you will shift the patient on ACE inhibitors. Okay, so I will tell you one other protocol. If some patient is there in your hospital and patient HB is less than 8 and patient presented with symptoms of anemia, then you will do the blood transfusion. If HB is 8 and there are no symptoms of anemia, there is no need for blood transfusion. If HB is less than 8, symptoms of anemia, you will transfuse the blood. If HB is less than 7 and patient is not presenting with signs of anemia, so for less than 7 HB, this is the indication of blood transfusion. So there are some other protocols which I will just mention. Please keep in mind that if some patient is presenting with ischemic stroke or transient ischemic attack, you have to keep in mind, first of all I would mention that if some patient presented with MI, so after management of acute phase, you will give 5 medication, 2 for 1 year and 3 medication for lifelong. So for 12 months you will give clopidogrel and beta blocker, and for life you will give ACE inhibitors, you will give aspirin, and you will give statin. So keep in mind, if patient is presented with ischemic stroke or transient ischemic attack, you will give aspirin for 2 weeks and clopidogrel for life. It is opposite to MI. Patient presented with ischemic stroke or transient ischemic attack, you will give aspirin for 2 weeks and clopidogrel for life. If patient presented with ischemic stroke and atrial fibrillation, then what you will do? Then you will do aspirin for 2 weeks, and then you will shift the patient on warfarin or directly acting anticoagulant drugs. So let me repeat again that if patient presented with ischemic stroke, there is no atrial fibrillation, just ischemic stroke, then you will do clopidogrel for life. If patient presented with ischemic stroke secondary to atrial fibrillation, then you will do what? You will give warfarin for life, or you will give direct acting anticoagulant drug. So again I will repeat that for MI, aspirin for life, clopidogrel for 12 months. For ischemic stroke without atrial fibrillation, only clopidogrel for life. Ischemic stroke secondary to atrial fibrillation, you will do what? You will give warfarin for life. So if some patient presented with only chest pain, you have done the ECG and ECG is showing just T-wave inversions, nothing else. Patient presented with chest pain, ECG shows T-wave inversions. You have to keep myocardial infarction in your mind, myocardial ischemia in your mind, and initially you will give 300 mg aspirin, and you will also give low molecular weight heparin as well. So you have to give ACS protocol. If patient is presented with chest pain and ECG showing just T-wave inversion, you have to give ACS protocol. So now we will talk about hyperkalemia and hypokalemia. If some patient is presented with hyperkalemia, please keep in mind, if patient is presented with hyperkalemia, you will do the ECG, and in ECG you will observe peaked or tall tented T wave. If tall tented T waves are there in the ECG, you can suspect hyperkalemia. So what you have to do now? So first of all, you have to protect the cardiac membrane, and after protecting the cardiac membrane, you have to reduce the potassium from blood. So first of all, protect the heart. So to protect the heart, we will give calcium gluconate IV, or we will give calcium chloride. So if patient is presented with hyperkalemia, tall tented T waves in ECG, first of all we will protect the heart by IV calcium gluconate or IV calcium chloride. Then we will reduce the serum potassium by giving the insulin with dextrose. The main cause of hyperkalemia in cardiac patient is spironolactone or ACE inhibitors. So main cause of hyperkalemia is spironolactone and ACE inhibitors. And now we will talk about the hypokalemia. So if patient is presented with hypokalemia and you have done the ECG, if there are U waves in ECG, then this is a case of hypokalemia. So please, I will mention that which are the causes of hypokalemia. Loop diuretics and thiazide diuretics are cause of hypokalemia. So let me speedily tell you the causes of hypokalemia and hyperkalemia. Hypokalemia, loop diuretic, thiazide diuretic, vomiting and diarrhea, villus adenoma, renal tubular failure, Cushing syndrome and Cone disease. These are causes of hypokalemia. Hyperkalemia may be due to ACE inhibitors, potassium sparing diuretics, that is spironolactone, CKD, Addison disease and congenital adrenal hyperplasia. Now I will tell you the side effects of these three types of diuretic. One is loop diuretic, other one is thiazide diuretic, and the third one is potassium sparing diuretic. You know, loop diuretics you can include furosemide and bumetanide. In thiazide diuretic you can include bendroflumethiazide and indapamide. In potassium sparing diuretic you can include spironolactone and eplerenone. So please keep in mind that all the three types of diuretic can cause hyponatremia. Loop diuretic and thiazide diuretic will cause hypokalemia, while potassium sparing diuretic, this is obvious that it will cause hyperkalemia. Now you have to keep in mind that diuretic which are causing hypokalemia, they also cause gout. Diuretics which are causing hypokalemia, they can also lead to gout. Now one specific side effect you have to keep in your mind, that thiazide diuretics can cause hyperglycemia and potassium sparing diuretics can cause gynecomastia. Potassium sparing diuretic can cause gynecomastia and thiazide diuretic can cause hyperglycemia, that is diabetes mellitus. So now we will talk about the aortic stenosis. Typically in the scenario, there would be an elderly male which will be presenting with the exercise intolerance, and when you will do the chest examination you will hear that ejection systolic murmur. Elderly male presenting with exercise intolerance and you are hearing ejection systolic murmur, you have to think about the aortic stenosis. So this is very common in elderly males, that is over 65. Patient usually asymptomatic, but sometimes they develop exercise intolerance and sometimes they can also lead to syncope attack. So when you will do the chest examination, you will hear the ejection systolic murmur at the right second intercostal space. So then you will see that this is a diagnosed case of aortic stenosis. So now we will discuss about different type of arrhythmias. Briefly we will discuss them. So you can see that in arrhythmias we can discuss SVT, we can discuss torsade D pointers, we can discuss AFib, and we can discuss ventricular tachycardia. So first of all we will discuss that is supraventricular tachycardia. This is also called narrow complex tachycardia and this is also called SVT. So please keep in mind that narrow complex tachycardia is SVT and this is mostly occur in the young patient and this is episodic. Like patient can present on and off. Sometime patient can present after 2 months, then 3 months, then 2 weeks, then 3 weeks. So patient can present repeatedly to the hospital. So when there is a young patient and he is presenting with palpitation and apprehension, you will do the ECG and on ECG you see the narrow complex tachycardia, that you will see that complexes there are very narrow and you will unable to differentiate between P wave and T wave, then this will be definitely a SVT, that will be a supraventricular tachycardia. So the first thing which you have to do for supraventricular tachycardia, if patient is hemodynamically stable, you will do Valsalva maneuver or carotid massage. So first thing for SVT is carotid massage or Valsalva maneuver. If there is no relief after doing the carotid massage, you will do adenosine. You will give adenosine 6 mg. If there is no improvement with 6 mg, you will repeat 12 mg. Then you will give 12 mg. If still there is no improvement after giving the adenosine 3 times, you will do cardioversions. If patient is hemodynamically unstable and patient presented with SVT, then you will directly do the cardioversion. So let's move to if the patient is presented with polymorphic ventricular tachycardia, that is broad complex tachycardia. And please keep in mind, we are talking about torsade D pointus. In torsade D pointus, the tachycardia is basically polymorphic. You can see the different types of waves, different shapes of waves in ECG, different shapes. So that is why we are calling this polymorphic ventricular tachycardia. That is broad complex. Ventricular tachycardia will also be broad complex, but in torsade D pointus, along with the broad complex, this is polymorphic. There are different shapes of QRS complexes and different waves. So what we will give in torsade D pointus, we will give IV magnesium sulfate. So now if patient is presenting with ventricular tachycardia, then you can see the broad complexes in ECG, but the shape will be the same. There are you can say that if patient is presenting with ventricular tachycardia, complexes are broad and shape is same. This is ventricular tachycardia, and in ventricular tachycardia you have to give amiodarone. Please never ever try to give calcium channel blocker in ventricular tachycardia. You have to select IV cordron, that is amiodarone. Okay, if patient is presenting with atrial fibrillation, the mainstay, the drug of choice for treatment of the atrial fibrillation is beta blocker, that is metoprolol. If patient is asthmatic, then there is no need to give beta blocker. If patient is presenting with atrial fibrillation and patient is asthmatic as well, you will give calcium channel blocker. If patient is presenting with atrial fibrillation and patient is a known case of heart failure, then what you will do? You will give digoxin. Drug of choice for atrial fibrillation is beta blocker. If patient is asthmatic, you will give calcium channel blocker. If patient is having heart failure along with atrial fibrillation, you will give digoxin. So now we will discuss about hypertension and its management. So you can divide hypertension into stage 1, stage 2 and stage 3 are the severe hypertension. So stage 1 hypertension is clinic blood pressure could be more than or equal to 140/90. Home blood pressure could be 135/85. In stage 2 hypertension, clinic blood pressure could be more than or equal to 160/100, and blood pressure at home could be more than or equal to 150/95. But if blood pressure at clinic is more than 80 systolic or it is more than 110 diastolic, so this is severe or stage 3 hypertension. So for the management of hypertension, the first thing you have to keep in your mind is lifestyle modifications. Whenever they ask about the initial step in the management of hypertension, you have to pick the option of lifestyle management. Okay. So for the management of the hypertension, you have to keep one thing in your mind, that for the management of the step 1 hypertension, you have to look at the age of the patient. If your patient age is less than 55, then definitely you will start with the ACE inhibitors or angiotensin receptor blockers. If patient age is less than 55, start with ACE inhibitors or ARBs. If patient age is more than 55 or patient age is equal to 55, then you will do what? You will start with calcium channel blocker as a first line management of the hypertension. But keep in mind, let me repeat again for you, if patient is less than 55, start with ACE inhibitor or ARBs. If patient is more than 55, start with calcium channel blocker. But if patient is from Africo-Caribbean region, patient age doesn't matter. If patient is from Africo-Caribbean origin, then you will start the patient with calcium channel blocker, whatever the age of the patient is. So for step 1 hypertension, let me repeat, if patient is less than 55, start with ACE inhibitors or ARBs. If patient is more than 55, start with calcium channel blocker. If patient is from Africo-Caribbean origin, patient age doesn't matter here. You will start the patient with calcium channel blocker. If with the first step hypertension is not controlled, then definitely you will add what? You will add calcium channel blocker to the treatment. Okay, so if patient is taking ACE inhibitors or ARBs or calcium channel blocker as well, and patient hypertension is not controlled, so what you will do? You have to add the thiazide diuretics along with ACE inhibitors and calcium channel blocker. That means you will start the patient on triple therapy. If patient hypertension is not under control with ACE inhibitors and calcium channel blocker, you will add thiazide diuretics. Okay, let me give you one example. You can add from the ACE inhibitors, you can add enalapril. From calcium channel blocker, you can give amlodipine, and from thiazide diuretic, you can add chlorothalidine. Okay, or you can also add indapamide as well. So definitely if patient will take 3 drugs, her hypertension will be controlled. So if some patient is having resistant hypertension, he is not getting under control with these 3 drugs, so then what you will do? Then you have to look at the patient potassium levels. If patient potassium is less than 4.5 millimole per liter, then you will add the 4th drug. You will add what? You will add spironolactone, potassium sparing diuretic. But if the patient potassium is more than 4.5, then definitely you will add higher dose of thiazide diuretics. Okay, so first of all we will start with ACE inhibitors or calcium channel blockers. On the second step we will add the second drug. On the third step we will add the thiazide diuretics. But if with the 3 drugs patient hypertension is not under control, we will check the potassium. If potassium is less than 4.5, we will add spironolactone, potassium sparing diuretic. But if patient potassium is more than 4.5, then definitely we will increase the dose of thiazide diuretics. Next topic of our discussion is ruptured abdominal aortic aneurysm. Once there is rupture of abdominal aortic aneurysm, then patient will present with a sudden onset of severe abdominal pain, sudden onset of shock. That means patient will be in hypotension, and there will be absent lower limb pulses. Okay, so please keep in mind this classical triad for ruptured abdominal aortic aneurysm, that is severe abdominal pain, hypotension, and pulsatile tender abdominal mass. Severe abdominal pain, severe sudden hypotension, and pulsatile tender abdominal mass, then you have to think about ruptured abdominal aortic aneurysm. So please keep in mind this is a surgical emergency, and the most immediate, most initial investigation to see the ruptured abdominal aortic aneurysm is ultrasound of the abdomen. Okay, so if there is no ultrasound in the option, you have to go for CT scan of the abdomen. Ruptured abdominal aortic aneurysm is emergency. The most immediate and the initial investigation is ultrasound. If there is no ultrasound in the option, you have to select the CT abdomen. So please keep in mind that there is a screening program for abdominal aortic aneurysm in the UK. You have to keep in mind that to go for this screening, you should have men only, once only in the life, and in the 65th year of the age, and this screening is done by the ultrasound. Please keep in mind, men only, once only, in 65th year of age, and this screening is done by ultrasound. Next we will discuss about the heart blocks. So you can see broadly we classify the heart block into 3 categories, that is first degree heart block, second degree heart block, and the third degree or complete heart block. So second degree is further divided into Mobitz 1 and Mobitz 2. So now I will tell you that what are these heart blocks. So please keep in mind that in first degree heart block, the PR interval would be more than 0.2 seconds. If PR interval is more than 0.2 second, or if PR interval is more than one large square, If PR interval is more than 5 small square, this is first degree heart block. Only prolongation of PR interval is first degree heart block. So second degree heart block, Mobitz 1. In Mobitz 1, there would be progressive prolongation of PR interval followed by a drop beat. The PR interval will prolong progressively and that will end into drop of a beat. So this is type 1, Mobitz type 1. What happened in the Mobitz type 2? In Mobitz type 2, PR interval is constant. It may be prolonged, it may be at the normal, but it will be constant, but sometime P wave is often not followed by the QRS complex. If PR interval is constant and P wave is not followed by the QRS complex, so you have to think that this is the Mobitz type 2. So now I will tell you that what happened in third degree or complete heart block. There is no association between P wave and QRS complexes. So let me again repeat these blocks for you. In first degree heart block, there is only prolongation of PR interval. In Mobitz 1 type 2 heart block, there will be progressive prolongation of PR interval with a drop beat. In Mobitz type 2, PR interval will be constant, but sometime P wave will not followed by a QRS complex. In third degree and or complete heart block, there will be no association between P waves and QRS complexes. So let me tell you about the management of these heart blocks. Please keep in mind that we will do nothing for first degree heart block and Mobitz 1. We will do nothing for first degree heart block and Mobitz 1 if patient is asymptomatic. And treatment option for Mobitz 2 or third degree heart block is permanent pacemaker. So we will treat Mobitz 2 and third degree heart block, and the treatment is permanent pacemaker. Okay guys, so this is very important topic. Now we are going to discuss about the heart murmurs. Please keep in mind that murmur is basically an abnormal heart sound. So there are two major vessels, and one is the aorta, the other one is pulmonary trunk. In aorta we have aortic valve, and pulmonary trunk we have pulmonary valve. And there are two major valves in the heart. One is the mitral valve and the other one is tricuspid valve. So please keep in mind that aortic valve may be stenosed, it may regurge. Pulmonary valve may be stenosed, it may regurge, and same is the case with the valves of the heart. Okay, so now I would like to mention about the position where you can detect the problem whenever there is stenosis or regurgitation of the respective valve. Please keep in mind that we can hear the any voice of aortic valve in the right second intercostal space, lateral to sternum. Right second intercostal space, always we will hear to the voice or murmur of the aortic valve. Okay, and at the same time, when there is a problem with the pulmonary valve, we will hear this problem in the left second intercostal space, lateral to sternum. So this is very important. On the right side aorta, on the left side there is pulmonary valve stenosis or regurg sound would be there. And now I will tell you that where you will hear the murmur of mitral valve and tricuspid valve. So always keep in mind that mitral stenosis and mitral regurg murmur you will hear at the apex of the heart, that is left fifth intercostal space in the mid clavicular line. This is very important. Okay, whenever there is problem with the tricuspid valve, you will hear at 4th to 5th intercostal space over the left sternal border. Mitral valve is mid-clavicular line in the 5th intercostal space, that is at the apex of the heart, and tricuspid valve in 4th or 5th intercostal space over the left sternal border. So this positioning is very important. Whenever you are clear about the position of these heart valves, it would be very easy for you to detect the murmur. Okay, now I will start with the murmurs. The first murmur, there is a aortic stenosis. If there is aortic stenosis, definitely there could be aortic regurg as well. The other one is pulmonary stenosis, definitely there could be pulmonary regurg as well.
So first of all, we will talk about the murmurs of these major vessels. So please keep in mind that if there is aortic stenosis, there is stenosis of aortic valve, and left ventricle is trying to pump the blood, and in the front of the left ventricle there is stenosis of the aortic valve, what would happen? Can you please tell me the type of murmur? So definitely, as left ventricle is creating a lot of force, so there would be ejection systolic murmur, and you will hear this murmur on the position which I have just mentioned. Okay, and what symptoms would be there when there is aortic stenosis? So keep in mind that aortic stenosis problem is very common in the elderly adults. I am sorry. So the patient will present with a complaint of dyspnea on activity, and there could be inguinal chest pain as well. So this is very important. The other problem with the aortic valve is aortic regurg. So whenever there is aortic regurg, so we can easily say that there would be a murmur of early diastolic. There would be early diastolic murmur, and we will hear the aortic regurg murmur on the same position which I have just mentioned. And whenever there is aortic stenosis, whenever there is aortic regurg, then definitely what would happen? Aorta is regurgitating and there is a lot of fluid in the left ventricle. There would be the symptoms of fluid overload, and patient can present you with the symptoms of heart failure. So this is very important. So let's talk about the pulmonary stenosis. As I have just mentioned about the position where you will hear the murmur of the pulmonary stenosis in the left second intercostal space. Okay, so what would be the murmur of pulmonary stenosis? Again, the same murmur, ejection systolic murmur, and patient will present with the symptoms of systemic cyanosis. This is very important. And one thing which I would like to mention, and I would repeat this thing at the end as well, that pulmonary stenosis murmur can radiate to left shoulder. Okay, this is very important. Pulmonary stenosis murmur can radiate to left shoulder. So now we will talk about the pulmonary regurgitation murmur. Again, there is incompetent pulmonary valve and it is regurgitating. So first of all, type of murmur would be early diastolic murmur, and we can heard at the same position where we heard the pulmonary stenosis murmur. So in pulmonary regurgitation, patient will present with the symptoms of right-sided heart failure. Okay, now I will tell you about the problem with the valves of the heart. So basically there are two valves in the heart that are, number one is the mitral valve, which is on the left side. The other one is on the tricuspid valve, which is on the right side of the heart. Okay, so problem could be the same, that there may be stenosis or there may be regurgitation. Okay, so first of all, I would like to mention about the position where you would hear the sound, the murmur of these valves. So first of all, keep in mind that if there is mitral stenosis or there is mitral regurg, you will hear the sound of these murmur of heart at the apex of the heart. So you should have a clear idea in your mind that apex of the heart is in the fifth intercostal space in the mid-clavicular line. Fifth intercostal space, mid-clavicular line, you will hear the sound of the mitral stenosis, and you will hear the sound of mitral regurgitation as well. So if there is problem with the tricuspid valve and there is stenosis of the tricuspid, there is stenosis of the regurgitation of the tricuspid, so then you will hear this sound at the fourth or fifth intercostal space, just lateral to the sternal border. Fourth or fifth intercostal space, lateral to the sternal border on the fifth on the left side. So this is very important. Positioning is very important. Once you have a clear idea about the positioning of the valve, then definitely you can easily assess that which is the where is the problem. Okay, so now I would like to start with the mitral stenosis. So keep in mind that mitral valve is stenosed, and keep in mind that which type of murmur could be there. As mitral valve is the stenosed and there is diastole of the ventricle, so definitely blood will come from the left atrium to left ventricle, but valve is stenosed, so you will have a diastolic murmur, mid diastolic murmur in mitral stenosis. Mitral stenosis, you will have mid diastolic murmur with an opening click. This is very important. Wherever in the scenario you see that there is written that there is problem with the clicking of the valve, so straightforward you have to tick on the mitral stenosis. So you will hear the sound of mitral stenosis at the apex of heart, and patient can present with the symptoms of heart failure, left-sided heart failure. This is very important. Now we will talk about the mitral regurgitation. When there is a regurgitation of valve, definitely when ventricle will contract, the blood will start regurgitating from ventricle to atrium, and you will have a pan-systolic murmur in the mitral regurgitation at the apex of heart, and patient will present with the symptoms of congestive heart failure, that is again the left-sided heart failure, that is edema, ascites, SOB, or anything like this. Okay, now we will talk about the tricuspid stenosis and tricuspid regurgitation. I have just mentioned that we will hear the sound of tricuspid stenosis and regurgitation in the fourth or fifth intercostal space on the left sternal border. So please keep in mind there is stenosis of the tricuspid valve, and what you will hear? You will hear a diastolic murmur, that is diastolic rumble. Okay, mid-diastolic murmur with opening click is a feature of mitral stenosis, and diastolic rumble is a feature of tricuspid stenosis. And patient will present with a complaint of what? Patient will complain that I have a fluttering sensation in the neck. Patient will have fluttering sensation in the neck in tricuspid stenosis. And in the tricuspid regurgitation, again tricuspid valve is regurgitating, and when right ventricle will contract, there would be a pan-systolic murmur, and you can hear at the same position like tricuspid stenosis. And what could be the symptoms of tricuspid regurgitation? Patient can present with right-sided heart failure, symptoms of right-sided heart failure. Now I will discuss about the congenital heart diseases in the children. Okay, so please keep in mind there could be two types of diseases in children that are congenital. There could be congenital heart diseases or congenital heart diseases. You have to keep 5 T's in mind for cyanotic congenital heart diseases. So 5 T's. Number 1 is truncus arteriosus. Number 2 is transposition of great vessels. Number 3, tricuspid atresia. Number 4, tetralogy of Fallot. And number 5 is total anomalous pulmonary vascular return. So these 5 T's are related to cyanotic congenital heart diseases. Now I would like to mention about the name of cyanotic congenital heart diseases. Please keep in mind that ASD, VSD, PDA and coarctation of aorta, these are the part of cyanotic congenital heart diseases. Now I will discuss about the important one from where you can have MCQs in your exam. So we will discuss only those diseases. So first one is PDA, patent ductus arteriosus. In this what happened? This is basically an cyanotic heart disease, and the problem is there is a connection between pulmonary trunk and descending aorta in the patent ductus arteriosus. So due to this connection the problem arises. Okay, so the important thing which you have to keep in your mind that premature preterm baby, wherever there is given in the scenario that premature or preterm baby, you have to think about PDA. P for premature, P for preterm and P for PDA. And what would be the type of murmur? Continuous machinery murmur would be there. If there is mentioning of preterm or preterm baby in the scenario and continuous machinery murmur is given, definitely there would be a problem with PDA, patent ductus arteriosus. And what you will do, the diagnostic test would be echocardiography, and the treatment here is indomethacin or ibuprofen. Indomethacin or ibuprofen is the treatment for PDA, and echocardiogram is the diagnostic test. Murmur is continuous machinery murmur, and this is very common in preterm premature babies. Okay, so let's move to the other one. Now we will talk about the tetralogy of Fallot, TOF. This is basically a most common cause of cyanotic congenital heart disease. TOF is a cyanotic heart disease, and let me tell you that in TOF there are basically 4 problems. There would be VSD, ventricular septal defect, and there would be right ventricular hypertrophy, and there would be obstruction of right ventricular outflow tract, that is pulmonary stenosis. So because of the pulmonary stenosis, there would be a murmur. The murmur of TOF is basically due to pulmonary stenosis. So we have just mentioned in the previous topic that in the pulmonary stenosis, the murmur would be ejection systolic murmur. And the fourth thing in the TOF is overriding aorta. So VSD, right ventricular hypertrophy, pulmonary stenosis and overriding aorta, these are the four things which we observe in the tetralogy of the Fallot. Okay. So what are the features that patient can present? So patient, basically this is a cyanotic heart disease. Patient can present with a cyanosis, and patient can present with a ejection systolic murmur that could be due to pulmonary stenosis. Okay, when you will order the X-ray of the patient, there would be a boot-shaped heart on the X-ray. On chest X-ray, boot-shaped heart, this is a feature of TOF. And ECG can show right ventricular hypertrophy. So nothing to do with the patient. The only treatment option is surgical repair. So this is very, very important. From both of these topics, like from PDA and from the TOF, you can have MCQs in the your exam from the pediatric portion. Now I would like to discuss about the tricuspid atresia. Patient can present with the cyanosis because this is again a cyanotic heart disease, and please keep in mind that there would be a progressive cyanosis. Patient can present with the progressive cyanosis. Patient can present with poor feeding, hollow systolic or pan-systolic murmur along the left border. So please think about when patient is presenting with progressive cyanosis and poor feeding along with the cyanosis, and there is pan-systolic murmurs, you should think about the tricuspid atresia. The other one, if patient is acyanotic and there is a pan-systolic murmur, please think about the VSD. If patient is a progressive cyanosis and there is pan-systolic murmur, think about the tricuspid atresia. If patient is acyanotic and there is pan-systolic murmur, you should think about the VSD.